Right, I think we can start because we've got a quorum already. So please invite the administration in. I believe members have got two new papers, CB21538 and CB21515. The first one is the administration's response to issues raised by members last time. And the second one is a response from the administration on the legal and drafting aspects of the bill. In fact, our legal advisor put some questions to the administration in writing after the last meeting. And the administration has given us a response. So I will not read out the names of the officials attending today's meeting. I believe members have already got the attendance list. So we've got the administration's response to issues raised by members last time, and we also have the administration's reply to points made by the legal advisor concerning the legal and drafting aspects of the bill. If there's no objection from members, we can deal with the response to the legal and drafting aspects when we come to our clause-by-clause scrutiny of the bill. Last time, members raised issues on the policy aspects of the bill. So, members, do you have any further questions on the policy aspects? Last time, some members asked questions which were not really specifically related to the content of the bill. So it was a rather general discussion last time, but today I hope that members will restrict themselves to issues relating to the bill. And if there are no further questions, then we can proceed to clause-by-clause scrutiny. Next Monday, on the 26th, we're going to have a public hearing at 4:30 p.m. We're going to meet the deputations. I understand that we've already invited deputations to come, and Wednesday is the deadline for indicating attendance. All right, do members have any further questions on the bill? And all right, if there is no objection, then we can start clause-by-clause scrutiny. So can I now invite the head of the e-record office to take us through the bill? Yes, thank you. The bill can be divided into a few parts, Chairman. First, part 1, preliminary. We seek to explain the purpose of the bill. And the Secretary may appoint a day on which the ordinance shall come into operation, and that's clause 1. And then clause 2, interpretation. We have the definitions of, for example, healthcare provider, joining consent, and so on and so forth. Yes, can you please take us through the long title? We seek to establish an electronic health record sharing system, and we need to have provisions on the sharing and using of data and information contained in the system, and the protection of the system, data and information. And The bill empowers the Secretary to appoint the Commissioner for the Electronic Health Record to be responsible for the day-to-day operation of the system. Thank you. Do members have any questions? No? Then we can continue. So preliminary, part 1, preliminary, short title and commencement. This ordinance may be cited as the Electronic Health Record Sharing System Ordinance. And the ordinance comes into operation on a day to be appointed by the Secretary by notice published in the Gazette. And then next, interpretation. And we have terms used in the bill. Do I need to go through these terms one by one? Members, do you think there is a need to do so? Perhaps members can take a look at the terms. And do you have any terms that you would like to get an explanation or elaboration from the head of the office?
Hi.
Chairman? Yes, Mr. Low? Are we on this part? Interpretation, yes. Parents or parent. Now maybe the data belong to minors. And so the father or the mother has certain responsibility concerning the release and the protection of the data. That's why we have the definition of parent here. But then we don't have the term guardian. Now, what if the child doesn't have a natural father or a natural mother, and an adopted parent, or a stepfather or a stepmother? Mr. Low is correct, Chairman. We have the definition of parent here because we have in mind minors, in other words, those below the age of 16. They are not able to make the decision themselves. And so we need to have substitute decision maker arrangements. And we have defined who can become substitute decision makers. There are a few categories of people who can make decisions on behalf of minors. Because there may be some lack of clarity concerning the definition of parent, whether it refers to only the natural father or natural mother, and that's why we've included the definition of parent in the interpretation. And in fact, in the clause on the substitute decision maker, we specify who can make the substitute, who can make the decisions. Then yes, perhaps we can look at the definition of guardian when we come to the relevant section, Chairman. And I understand that there is also an entry, substitute decision maker, in this clause. So let's look at it when we come to it. Chairman, concerning shareable data, Chairman, it says shareable data means index data of the healthcare patient and the health data of the healthcare patient. So in future, patients can decide what data to release to which medical organization. Yes, a patient can choose the medical organization concerned. But what if a patient doesn't want a particular organization or a particular medical officer to have access to some of his records? Now, in fact, there was some discussion in the Health Services Panel. Divergent views were received. Now, some are of the view that the medical personnel possess the medical records, and so they can decide what data to upload onto the system. But then some are of the view that if some parts of the records are missing in the system, then that may be rather dangerous to the patient concerned and to the doctor in charge. And so there are these very different views. And I understand that in overseas countries, they have the safe deposit box arrangement whereby the patient can put certain information or data into the safe deposit box, and we'll deal with this issue when we come to stage 2. We will in stage 2 study international practices. And I want to say that in stage 1, we don't have the safe deposit box arrangement, but I want to say that the legislation is drafted in a neutral manner, and the legislation will not rule out this possibility. But you haven't said under shareable data, not including data to which the patient has not given consent to release. If we have the safe deposit box arrangement in the second phase or in the second stage, will the legislation have to be amended? It depends on how the arrangement is designed. Now, maybe not all patients are interested in making use of the safe deposit box arrangement. Some patients may prefer to have the full records released to all the medical personnel. Can you include under shareable data, excluding data to which the patient has not given consent to release? But then if we add this remark, then that would mean that we will be implementing the safe deposit box arrangement. I want to say that at the moment there are no preconceived ideas. If you insert this part, then that would restrict the flexibility of the system, and that would mean that there will be a safe deposit box arrangement. But then if in future there is the arrangement, then will the legislation have to be amended? Maybe yes, Chairman. But we will, under stage 2, study international practices on the safe deposit box arrangement.
If we think that particular design is necessary, then we'll see whether we need to amend the law. Maybe there isn't a need to amend the law, but just introduce some administrative measures would be enough. So at this stage, we don't know, because that is something that needs to be studied further. Can you wait? I think for the definitions, we need to look at what's in the bill. Well, I'm open to other members' opinions. I think that, as you said, that there is opposition during the consultation. That's why I wanted to hear more views first. Okay, Kwok Ka-ki next, but before he speaks, I'd like to remind members that we're looking at the Chinese and English versions at the same time. If you don't object, we will not look at English and Chinese versions individually. Is that okay with you? Okay. Kwok Pui-fan's question. Let's see if you want to ask any follow-up on that. Questions on that. And when we look at the clauses, we might go back to the wording of shareable data. So you can raise similar questions or related questions then. Now, Kwok Ka-ki next. Chairman, I wasn't quite pleased with the reply, because when it comes to legal definitions, if you don't have a clear definition before the bill is passed into law, and then if you will issue administrative orders later, I think that's not the way to go. We can't just muddle things through like that. If you want to define insurers later, you must actually have a clear definition now, so that we can know for sure what it means now. Sometimes we debate about the legislative intent, but if the Bills Committee has not reached a consensus on ways to protect patients' interests, then, Chairman, next time when the same issue is put before the committee, Chairman, you and I may not be here anymore. So I'd like the legal advisor to clearly point out what the intention is. If there's a big hole left there and terms are vaguely defined, then I think we need to sort that out. And also patients, when they decide on their insurer, we need to respect their privacy. In the future, two types of patients will be affected. One is the mentally incapacitated persons who will be greatly affected. People in mental hospitals, they are defined as mentally incapacitated. But, this group of patients may have to know whether their rights are protected. And also, in the future, when the shareable data of patients is widely used, I did ask this before, then doctors appointed by employers or medical practitioners, they can have access to all the data. Say your employer says that you must sign this document authorizing the employer to have access to your medical data. I don't know if you remember the Cathay Pacific incident. Cathay Pacific asked its cabin crew to give the company access to its medical records. There was a great controversy then, because that could give an excuse to the company to actually hire or not hire you, depending on whether you sign the document. If the government doesn't think it's important and doesn't want to protect such right, the employee's right, and then now you're not making any promise or just make a very fake promise, then I can't accept it. We need to make it very clear at this stage. And secondly, I don't know what you mean by Chairman. I found it strange that we haven't even had our public hearing. And LegCo does have the power to draw a line on controversial topics like this. If we know what the public thinks after the hearing, say on the definition of insurers or the protection of rights to personal data, we should not say now that we will see how things go in the future. We can't leave a loophole unplugged here. We're talking about legislation. So, Director, could you supplement, explain clearly? What's the decision when you consulted the insurers? How did you come to the decision during your consultation, when you had a consultation with the insurers? In the end of 2011, early 2012, we issued a consultation document on protection and privacy and legal framework of the system. And in our document, it's mentioned that there is this safe deposit box concept. That is for some patients, if they think that there are certain kinds of records do not want to be shared, then whether the patients have the right to allocate those records to the safe box, and the box won't be opened by anyone, or even by some family doctors or medical practitioners. And the document explains such arrangements. And the document also that explained that if patients want to protect his privacy to certain kinds of information, then there should be a mechanism or arrangement for that person to keep those data private. But for the medical or healthcare providers, the providers may not know what sort of data is missing from the data pool. So that may not be actually to the benefit of the healthcare recipients. So what sort of data can be taken out? For example, if the patient has certain kind of disease, he may want to decide on deleting the medical consultation documents with a certain doctor. But say the drugs used by a patient could also provide clues to the kinds of diseases this patient had before. During our public consultation, we received more than 100 submissions. And the results show that there are two camps of opinions. One camp was of the view that the patient should have the right to decide to withhold some kind of data. And there were also a lot of submissions that said, well, the record should be made public. If the patient actually, it may not be the benefit to the patient as well if some information of his past diseases was withheld. We know that there are many countries in the world that actually adopt a similar system, and therefore, back then, in the first stage of this program, from 2009 to 2014, we came to the conclusion that in the second stage, that is after 2014, we would look into the overseas practices and the safe deposit box arrangement. How can it be done? And what sort of system can be designed? So we will carry out a study on these issues in the beginning of the second stage of this program. So we didn't come to any conclusion whether we should go ahead with the safe deposit box idea or not. We will, however, look into the practices overseas, and then we'll come to the task of designing a system. So there's no need to amend the current law now. We are only discussing what is shareable data. And in the future, actually under the bill, the shareable data relates to index of the patient's medical records and also health records of a patient. So we have tried to define the meaning of shareable data. If you want to define something as a safe deposit box, then I think it's not the right time to do that yet. We'll be jumping to conclusion if we define safe deposit box at this stage. Okay, I'd like to ask the legal advisor whether the director's explanation is appropriate. And secondly, Chairman, in reality, a lot of patients, depending on where they are, for acute patients, hospital authority has its own system that stores most of the important information. For example, what sort of drugs a patient is sensitive to. And all this information are on the patient's medical records. And within HA, it has actually kept the most important information. But in reality, information actually is available on not just a person's acute diseases, but also on all sorts of sensitive and non-sensitive data. So therefore, let me give you an example. For example, sexual orientation. Such is a very sensitive topic. If a patient in the past have been diagnosed or consulted psychiatrists in relation to his sexual orientation, then he has the right to protect such information. You're talking about acute or emergency cases. This has nothing to do with acute diseases, but you do need to have a mechanism under which the patient can choose safely then you can be providing help to a patient. If as the patient, I know that I have no right to decide what sort of data can I have exclusive access to, then you try to encourage patients to authorize, right? To authorize other people to have access to the data. You're encouraging sharing of data, right? But if you say that patients have no right to decide what of his data can be kept or shown to others, then when you have to make a judgment on what should come first or later, you can't say, well, I have no definite view on this. If you have no definite view on this, that means you're still at an immature stage when it comes to the lawmaking. You have to make it very clear. You can't just wait and see how things go. But I do like to listen to legal advisor's views on what you think of the government's explanation. Whether you think the approach now has a loophole?
Legal advisor, do you have anything to say at this stage? Thank you, Chairman. Yes, perhaps I can share with members my observation. Now, with regard to the definition of shareable data here, it doesn't provide for the possibility of a safe deposit box arrangement in the future. Now, in fact, in the law, there are ways to provide for an element which has yet to be designed and implemented. But whether that should be included in the bill at this stage is not a matter of a legal nature. So this element, the safe deposit box arrangement, is not provided for in the framework at this stage. But in future, what if they decide to implement the arrangement? And if we pass the legislation as it is, then will irreversible consequences arise? Will an irreversible situation arise? Legal advisor, I wonder if the administration would like to supplement. My understanding is that if the policy changes, then the legislation can be amended. No, because he mentioned administrative guidelines or orders as well. He has mentioned a few things. I think he has mentioned 3 things. First, if it is written in the law and not implemented, then the definition will become unclear. In other words, if because there will still be consultation and views are divided. And then the second thing is, at the moment you can't find it in the law, but then in future it can be added into the law. And the third option is administrative orders or guidelines. Is the third option sound? And will the arrangement be open to legal and judicial challenges? Yes, thank you, Chairman. Now, as to whether we've already come to a firm view, as I've explained, in fact, in our steering committee, in the working group, we have also representatives from the Medical Association. And there are views against a safe deposit box arrangement. But of course, there are also views for such an arrangement. So the public's views are divided on the matter. And we've promised that there will be a detailed study in stage 2. So we'll look at the we'll look at overseas experience, how many safe deposit box systems there are that we can make reference to, and whether we should have such an arrangement in our public healthcare system. And then even if we are to have the arrangement, will the functional requirement dictate that we need to amend our present legislation. So first of all, we will have to look at whether the definition needs to be amended, and second, whether administrative orders would suffice for us to implement the arrangement. So that was what I was trying to explain to members. If in future the legislation needs to be amended, if the government feel that the legislation should be amended, and of course we will go down that route. But then if we include a definition of or a provision on the safe deposit box arrangement, then that may be implied to mean that in fact we've already jumped to that conclusion. All right, this is a rather important issue, and that's why I'll allow members some more time to discuss this matter. Now, Mr. Kwok has asked a question, and that is whether in future administrative orders are sufficient to implement the safe deposit box arrangement. It seems that you haven't really given an answer to this question. Is it because you haven't really got a design of that arrangement, and so you can't tell us whether administrative orders would be sufficient, or whether the legislation will have to be amended? I believe members tend to think that having a definition in a definition would be more secure. Yes, perhaps I can put the matter this way, Chairman, to facilitate members' understanding. Now, in the bill, we provide a definition for shareable data, and we do not provide an exhaustive list of shareable data. Why is it that we are not providing an exhaustive list of shareable data? For example, past laboratory reports, allergies to certain drugs or medicine, and so on and so forth. The reasons are as follows. After all, we are only in stage 1. And then in stage 2, we are going to include more data to be shared. For example, X-ray films, family history, family medicine, or medical history. So these may be included under stage 2, and that is why the legislation merely seeks to provide a framework so that in future, when more data are to be included, or when certain data are to be excluded, we will not have to amend the legislation every time we do such a thing. And so as to what data will constitute shareable data. Now, in future, we may have operation or administrative action. Say, for example, we may write to medical organizations informing them that more groups of data will come under the definition of shareable data. So that's the rationale behind the present form of drafting. Now, concerning a safe deposit box arrangement, that means excluding, say, certain types of data out of the dozen, that all right. Perhaps members may wish to follow up later. Some members may get more and more worried as they hear more and more from you, because it seems that the government may be able to, in an administrative manner, include more data as shareable data. So the concern is not restricted to the safe deposit box arrangement. Mr. Joseph Lee, now I think I will go back to the 5-minute limit. I want to remind members that we are now doing clause by clause scrutiny, and we are on clause 2 interpretation. Right, Dr. Joseph Lee? Thank you, Chairman. I have no intention to argue with you over the time limit for each member, but in fact some members spoke for over 10 minutes. But anyway, I want to say that concerning shareable data, it's a very clear term, both in English and in Chinese. And then concerning the safe deposit box arrangement, how it's going to operate. Now, under the definition of shareable data, it doesn't preclude or exclude the possibility of a safe deposit box system. So I think in the legislation, we need to make patients fully aware of what data can be shared. Now concerning these e-health records, the bill is silent on to whom the records belong. I don't know whether the concept was discussed at the last meeting or before I came in. And the situation is very different when we're talking about public sector hospitals and private sector hospitals. Now, in public hospitals, the records belong to the public sector, not to the patients. And for private hospitals, patients do not have access to all their health records. And now, it is hoped that there can be sharing of the data belonging to the patient between the public sector and the private sector, and the system seeks to allow the patient to exercise this choice. But at the moment, public hospitals do not need to ask the patients whether they can pass the data to the private hospitals, because medical records in the public hospitals belong to the public sector. And if I want to take my public sector records to a private hospital, I have to apply to the hospital authority. But then, say a private doctor may feel that he needs to know the patient's records kept by the hospital authority. And there is a need to obtain the consent of the hospital authority first, apart from obtaining the consent of the patient. And my understanding is that the patient will not be consulted on what data that private hospital needs to have access to. So, now, I will not argue with you on whether we need a safe deposit box system, but I'm of the view that the drafting of the definition here is appropriate. We shouldn't set or cast everything in stone. But of course, what he said was quite alarming. I mean, when he said there could be he could rely on administrative orders. So it seems that you may bypass LegCo if you want to. You can have all the say. So I think you are really inviting challenge in making such a remark, Mr. Chan. But I want to say that if the patient is worried, if the patient has a lot of reservations, then he can choose not to give the sharing consent. Now, because under this system, this e-health record sharing system, you have to have the consent of the patient before there can be access to his health records. Now, I thought the matter was discussed last time, and that is who owns the health records. The issue of ownership. Last time the issue was raised, but there was no detailed discussion. I think this is very important. This is a very important point. Say if I go to a private medical practitioner, I go to Dr. KK Kwok, and or do my medical records belong to me or to Dr. KK Kwok? So I think this is a very important issue. Yes, I think that's the present situation, but what's going to be the future arrangement? Now, I say I'm a nurse, and of course I want to have access to the medical records. But then, what if the records I put in a safe deposit box? That can be rather worrying. So yes, let them reply. I just want to say that we are not merely concerned about what shareable data mean. I think the definition is okay here. But then I think the fundamental issue is who owns the health records. So I believe they understand your question. And I want to supplement here. If the patient owns the medical records or health records, if that's the definition, then in other words, does that fall into fall within the definition of personal data? Now, Chairman, allow me some more time to finish my argument. Now, because if you don't make this clear, patients may have the belief that they own the health records, and so they may decide what to put into the safe deposit box, and as a result, that may defeat the purpose of the e-health record sharing system, and that is to allow medical officers concerned, medical personnel concerned, to have access to the patient's past health records so as to better help the patients. Now, in fact, in the hospital authority, e-health is being implemented. I believe those from the hospital authority know very well that e-health records is being implemented. There is the CMS, and I think this is a very important issue. This is the fundamental issue. All right, Mr. Chan. So we want to know what the present situation is. For example, at the moment, it is assumed that the private medical practitioners own the health records, but in fact the situation is not clear. And then with the passage of the bill, who will be the owners of the health records? If the health records belong to the patients, then are these records the same or enjoy the same status as data under the the Personal Data Privacy Ordinance? Because under the Personal Data Privacy Ordinance, data subject can request that certain data be deleted. As to who owns the health records, Chairman, in fact, we had a detailed discussion in the working group. Now, my record, all right? This term may give rise to different understandings and interpretations, and that's why we have to clarify the concepts. And in fact, under the Personal Data Privacy Ordinance, there is an explanation. Now you're the data subject, so in other words, that the document contains data relevant to you, but it doesn't mean that you own or possess the data or the document. Let me give you another example.
When it comes to data sharing, in future, the data will be provided by various participating organizations. For example, laboratory tests results. So outcome of laboratory efforts, and there can be also data from doctors who's actually put down in writing his diagnosis of a patient's disease. So it's not that each part of a medical report is owned by a patient. The patient is only the data subject. Why is it that, for a single medical record, there are various contributors to such record? Our design is that for each participating medical institution or patient, they need to sign in or fill out an application form on which there will be clauses explaining to them that by joining the scheme, they have agreed to share the information or the data originated from them. So that's our initial design. Now that the system is not up and running yet, whether for private or hospitals or public hospitals, why is it that data can be shared among hospitals in the absence of the law? Well, later on I can ask my colleague to supplement the practices of the hospital authority. But no matter which medical organization you go to, there's normally a document called patient notice, alerting patients to the fact that the information about their diseases may be passed to a third party in relation to the same disease. So now, may I ask Dr. Wong to supplement? Dr. Wong? Thank you, Chairman. for the hospital authority now and for all medical practitioners in Hong Kong when they want to collect patients' medical records, of course, they need the consent of the patients involved. We would actually, at the entrance of a hospital, we do have a notice for all patients telling them how the hospitals would get information about the diseases and share them with other medical professionals for the purpose of providing medical services. So patients are informed now. But of course, for the purpose of providing medical services. Under existing laws, for example, the Hospital Authority Constitution and Professional Conduct for Medical Professionals, medical or healthcare providers need to keep and ensure that patients' data are accurate and up to date. Therefore, in principle, that also gives the hospitals and healthcare providers the right to have access to the records. And since the records, contain information of a patient's medical history, therefore, under the Privacy Ordinance, a patient has the right to request data access, to make a data access request. And if the data is used for secondary purposes, then patient's consent is required. So under the current system, in the future, Commissioner for EHR, he needs to actually ensure the security and legal framework of the future sharing of e-records. And patients' consent will be required for sharing data. And we mentioned many times before, whether patients should have the right to decide what sort of data can be shared or not. We understand this is a matter of choice for patients, but whether this should be an absolute right, whether it's mature at this stage to give patients the absolute right or such right, I think we can't come to a decision yet. Now, as Mr. Kwok just mentioned, people did say to us that they're worried whether, for example, for some people on psychiatric medication, and would the patients not want to be labeled by revealing the fact that he is on psychiatric medication? Or, for example, if the healthcare providers are not aware of the disease of a patient. I was in emergency ward for 9 years, and I've seen many cases where the patients, patients who are on psychiatric drugs, may not be able to know or to tell what sort of problems they have. So we think that psychiatric information is sensitive information, but still, that's still the concern, as raised by Mr. Lee Kwok Leung, that if we are providing services to a patient, the patients themselves actually could be at risk if not all of his medical history or information of his medical history is made known to the healthcare providers. So our scope now, I think there needs to a simple, efficient method to ensure the phase 1 implementation of the scheme. I think the head of the office was talking about, ownership of data, but basically now we don't have any definition on what constitutes the right or what the right of a patient covers. Who owns the data. So simply put, I think this could be an answer to Mr. Lee's question. Of course, in the second stage, if we have the patient portal, then people will think that people have access to patients' data through the portal. So it's a matter of perspective. What constitutes my data? Thank you for your supplements. But if you look at the way that it's written in the bill, I'm worried that there's no provision to clarify the matter in the interpretation, and 5.2 in interpretation does not spell out. Do you call it my record? Are you talking about my record or patient's record? We haven't defined these two concepts. I think you should put down patient's record instead of my record. That means maybe patient's records are the records that the patient agree can be shared by various institutions. Whether we have a safe deposit box is another matter. But I think in interpretation, we need to clarify, we need to spell out very clearly, concepts about whose records we are talking about. Because patients may think that after I've signed, he thought that after he signed Yihao, then he owns the document or the record. Okay. So members have queued up to ask questions. Government Council wants to supplement? Yes. Let's not talk about safe deposit box for now, but if you look at health records, the definition of health records, shareable data includes registered recipients' health records, and the definition of health records does not say what is not covered by the records. And just as the administration says, X-ray results would not be included in the health records. So if we pass the bill the way it is now, then the administration can issue administrative orders to list out what is not covered by health records. So members, please note you have no right to vet administrative orders. Okay, let's go back to this question later on. You may have questions, other questions, and you can see how we can plug the potential loophole. Kwok Pui Fan next. Chairman, I think all along the government has been talking about launching e-health records, and the purpose is that it will be patient-centered and it will respect, all along the government has said it will respect patients' right to know. So I think many members of the public have the impression that they will not go into the technical issues of who owns what, but the public may think that at least they would think that they should have the right to choose whether to make public some private information. So talking about the purpose, the original intent of this system, you cannot neglect the fact that you did say that you would respect patients. You did promise that patients' privacy would be respected when you made a plan for the e-health record sharing system. I agree that after your consultation, you should now have a clearer view of the way to go. But I think you should not just look at the successful cases overseas. Hong Kong is ahead of many countries already in e-health records. We can't follow everyone. Shouldn't we think clearly what we want to do? We can take the lead instead. That may be even better. And on the other hand, I believe that our healthcare professionals can identify what sort of data can be kept private without affecting the treatment of the disease. For example, a woman who's gone for medical consultation for a cold need not tell a doctor that she had abortion or sex disease before. I'm sure healthcare professionals should be able to tell what sort of data they need to know to treat a particular problem. I think that's achievable. At this stage, the way that it's written in the bill, If you want to keep the flexibility, of course, you can have flexibility. But what worries me is your mention of issuing administrative orders in the future. So I'd like the Government Council to tell us what you think. Are there any ways we can plug the loophole? We can't just let the government decide what sorts of administrative orders it wants to issue in the future, over which we have no control. We will have no control in the future. Yes, are there any ways we can handle this? Chairman, my original proposal is for the government to consider adding to interpretation, that is, health records agreed upon by the patient, or health records of a patient but not including those that he does not want to review. Shall we settle this? Yeah. Are there ways we can plug the loophole? Yeah, I think this actually is mentioned by someone. Sometimes patients may not know that, or maybe a patient may not know that, the code that he's getting treatment for, may actually, be treated effectively with knowledge about her past, information, like that he had, like for example, she had abortion. Well, I think that this is a policy decision. If we follow the bill the way it is written, and if there's no amendment to this bill, we would not have actually, then we're not scrutinizing. We just let this bill pass and we're not scrutinizing it. Yeah, can you do something? Can something be done to ease our worries? Because I don't want the government to be able to do whatever it wants later on. Yes, what do you think? What do you think, Mr. Chen? Yes, supplements. As I said, in the future, we may issue administrative orders, use administrative means to, if there's a need, after we've conducted a study, if we need to issue administrative orders, then we'll, as I said earlier, well, I wouldn't use the word orders, but we can use administrative means to handle the problem later.
So we will announce what additional data will be shareable, and so on and so forth. I want to say that it's not our position that as this arrangement is not provided for here, it will not be implemented. We simply think that as there are divided views, and so we will need to carry out a further study before we come to a conclusion. And even if we are to implement the arrangement, it doesn't mean that legislative amendments are definitely required. There are other options available. And then we have to make sure that the system can allow the patient to exclude 3 out of the 10 categories of shareable data, and so we have to bear in mind the possible technical difficulties, and we should not put in something that we don't know whether we can implement or not. And then, as a member has pointed out, we want to set up a framework for the sharing system, and we're not trying to preempt anything or preclude anything at this stage. So the framework will be established, and then we'll see whether we can put in place the arrangement. But then members are concerned as to whether revisions will be implemented only after getting the green light from LegCo. Of course, the LegCo will have to be consulted again. Firstly, we haven't applied for funding from the FC yet for the second stage. And then second, we have to keep seeking the views of the HS panel on this system, Chairman. In fact, when we had the public consultation exercise and then when we got the outcome of the exercise, we told the panel, we reported back to the panel that there were divided views on the safe deposit box arrangement. And so as to whether we are going to do it or not in the future, we will make a final decision only after having consulted the HS panel. Yes, please be concise. But then it doesn't say here that you may implement the safe deposit box arrangement through administrative means. So does it mean that if there is stage 2, you'll come back to LegCo and the legislation will have to be amended? Can I assume that after stage 2 there will definitely be new elements, and as a result the legislation need to be amended or must be amended? I don't think I can say this with such great certainty at this stage. So we have to look at, say, for example, the design of the safe deposit box arrangement, if there is to be such an arrangement. Dr. Joseph Lee, I have waited for a long time and it's still not my turn. But then you asked, Loh Wai Kwok, did you did you raise your hand first, or Joseph Lee? All right. I think you can continue. All right, Dr. Joseph Lee. Yes, I'll let Mr. Loh Wai Kwok ask his question first. Okay, Mr. Loh, thank you. Now 5.2 is very clear following this logic. So it seems that the healthcare recipients can choose to join the system or not. But then once he has joined the system, what data are to be included in the system is something for the commissioner to decide. Is that right? No, at the moment we don't have the safe deposit box system, and yet you want to give a choice to the healthcare recipient. How can he exercise the choice? And if the if only certain data, not all the data, are shared, then what advantages can there be in terms of helping the healthcare providers to provide better assistance to the healthcare recipients? Chairman, sorry, I was not able to attend the first meeting of the Bills Committee, but I think this is the fundamental concept. But then it seems that after an hour's discussion, we are still arguing over this concept. Chairman, 5.2 says that after the establishment of the sharing system, then two parties will be involved. First of all, the healthcare provider, the clinic or the hospital, and the second party is the healthcare recipient or the patient. And 5.2 says that, say, if the clinic needs to provide certain data for me, then what format should data be? And so the commissioner can require the laboratory, the clinic, or the hospital to upload the data in a certain format. Sorry, 5.2b is about the format, but then C is about the commissioner being able to make the decision, right? Yes, that's because we need to have some information from the provider or the recipient before the system can really operate. So 5.2c states that the commissioner can have to say as to what data or information need to be included in the system. So do we accept this principle, or are we saying that the recipient still have a choice? So I think we have to sort this out first. Or we can continue only after the safe deposit box arrangement is in place. Otherwise, I really don't know how we can really take the matter forward if we can't resolve this fundamental issue. Because when we say whether the recipient can give consent or not, then that's back to square one. Now, I think we all agree that there is no decision made on the safe deposit box system, and even if we are to all of a sudden decide that such a system or arrangement will be implemented, the system doesn't really have that technical capability. We're concerned about this. In future, the commissioner may decide personally what data can constitute shareable data, and the commissioner's powers will be excessively large. And so we are of the view that LegCo should be given a chance to scrutinize any changes. Yes, Chairman, I understand 52C says that the Commissioner can require that certain data and information be provided, or else the system simply can't function properly. We are of the view that operationally this provision is required. Then does it mean that the Commissioner can have all the say concerning what data can be shared and uploaded? This should not happen, Chairman. There are two tiers of protection. First, we've all along emphasized that the system operates on a voluntary basis for both the providers and the recipients. So the Commissioner simply cannot force all the patients to share their health records with the healthcare providers. And then second, if we are to include further items in stage 2, we'll definitely consult the HS panel and also our own working groups. We have to make sure that the idea is acceptable to the community. We can't simply have one person making all the decisions. So that's back to the fundamental point of giving the patient the choice. If he refuses to share the e-health records with medical organizations, then he can exercise that option. But then, of course, the purpose of the bill is to encourage the sharing of e-health records in order to benefit the patients. And as Mr. Loy-Kwok has said, what is the solution? It seems that the administration's solution is that if the patient doesn't like the arrangements, then he can opt out, or he can choose not to join, rather. Now, Chairman, so joining is on a voluntary basis, and if you join, then you are in fact accepting the Commissioner's powers under 52C. I want to say that if the data shared are piecemeal and not complete, then what good will this do to healthcare providers in terms of providing better treatment to the healthcare recipients? But then if we do not accept the Commissioner's power under 523, then the matter simply can't be taken forward. So it seems that if you join, you will have to accept the Commissioner's power. Dr. Joseph Lee. Now, Mr. Chan talked about 52C. I think 52C is about who owns the health records. I think the most controversial point about the bill is who owns the records. We are talking about patients' records, not my records. We're talking about health records. So back to Dr. Elizabeth Quat's point. The patient may choose not to join the system if he knows that there will not be a safe deposit box arrangement. But then at the moment, the problem is that the health records do not belong to the patient. So I think you are giving rise to unnecessary controversy. Now at this stage, of course, there is no safe deposit box arrangement. But then with this bill, you are giving patients the expectation that there may be a safe deposit box arrangement. So at the moment, patients really don't know. Say a patient may welcome the bill because patients' records will become my records. And then Mr. Chen just said, okay, if you don't accept the arrangements, don't join. So as a result, you do such a lot of things and nobody joins. So is that your objective? Are you defeating your own purpose? In fact, I also took part in the study on the system in 2009. We said that we wanted better sharing of health records for the benefit of the patients. On that point, there was no controversy. So I think you should clarify who owns the records so that patients know that the records do not belong to them, but then as the data relate to them, they need to be asked or consulted. So I think the fundamental issue is the fundamental issues are access and then privacy and then how the health records are to be uploaded onto the system. I don't know the technical details, Chairman. IT people know better than I do. But I think patients need to know, or the healthcare providers need to know what consequences there will be if I press this button, for example. I think you have to get the concepts right. Otherwise, I have to move a CSA. Because patients may come to ask me when I am in the ward, do you really have the right to have access to my records? So you are making life very difficult for frontline staff in both private and public hospitals. I want to say that I'm in this sector and I discovered this very big loophole.
So consider this, please. Doesn't matter if he doesn't want to answer. Can you offer any answers? Or well, I can discuss the issue with my colleagues. But I know you're trying to help me. For this bill, even if it's passed, it will not affect the actually provisions of the Privacy Commissioners or Privacy Ordinance. So if we were to specify who owns the health records, that a patient could only be the data subject, then I need to see, to ask my colleagues on this. We are talking about, trying to avoid misunderstanding. Please don't, create a piece of law that would cause misunderstanding. I think our government council will also look into the issue. So next time, we can hear answers from them. Emily Lau, next. Excuse me for being late. I was in Geneva last time, so I missed the first meeting. Personally, I support the sharing of data because this could provide convenience to healthcare professionals and could be beneficial to patients too. But I heard that, having looked at the, the objectives of the bill, is it to support the healthcare reform system? Or is it mainly to provide convenience and to allow for more or speedier treatment of diseases? Okay, you may have actually asked the same questions before. I didn't know. I know you need to handle questions or issues raised by our members, but I'd like to know what's the true objective of this system. Thank you. Well, the purpose of implementing this system is not just to support the healthcare reform. Mainly, it is out of the consideration that patients in today's world actually may consult the public system and also consult private doctors at other times. So the issue is, if patient goes to see a private doctor, then he will have no access to his medical records in other clinics or hospitals. And this is not ideal for the treatment of a patient's diseases. We need to have patient-centered services. If healthcare providers can have a more understanding or information on his past, on the patient's past medical history, it will be good to have such access information. For example, what sort of drugs or tests or procedures the patient had before. So actually having access to this information can actually make the treatment more effective. So medical records, if they can be shared among medical institutions, that would be an ideal arrangement. And that's the whole purpose of the data sharing system. We also hope that hospitals and patients can join after considering whether they want to join or not. Because there could be a large number of hospitals, medical institutions, or patients that choose to join. And if there's a large number of medical records to be shared, then there needs to be a legislation to ensure the privacy, security, and use of such records. And that's why we're proposing to legislate this bill. Chairman, are you a commissioner? Well, he's head. He's the head. Okay. Well, I agree with your objectives. This could, of course, bring convenience to the treatment of a disease. But why is it that members raise so many concerns? Are those issues raised actually insoluble, and also in section C or B that gives the power so much power? Can we find a compromise? The most important is that the patient can provide you with his information. So why can't have? How come that you can handle this actually issue till now? Yes, I think just then we were discussing mainly if we were to decide, within the first stage of the plan to allow for 10 types of information to be shared, then should it be specified in the law what these 10 types of information are? And secondly, if a patient says of these 10 types of information, I don't want to show particular kind of data, I like to have a safe deposit box in my record so that a few types of information could be locked and not be seen by all. Should such function be allowed for, and should we put it down in law, in writing? And that's what we were discussing. And there's also the concern that if we didn't spell it out, then would the 10 types of information to be decided solely by the government or the commissioner? That seems not ideal as well to members. So these are the issues we just discussed, and we heard as well during our consultation. I was trying to explain that the bill is only to provide a legislative framework for the operation of the system. Why don't we specify what 10 types of information to be shared? Because as the system develops, we may need to increase the types of information. Maybe now we can't allow for sharing of X-ray results. So X-rays are not or even family medical history is not stored at this stage, but in the second stage, maybe we can add a person's family medical history. So if we spell out the 10 specific types of education, that would require for legislative amendment in the future if I want to add another type of information. And also talking about the issue of if a patient wants to withhold some kinds of data, say, he wants to, deduct one kind of data from what's stored, then we need to discuss and look into further what we can do. If we have put down in writing in black and white the types of information, if we are to delete any one of them from the law, then we will have to make another legislative amendment. I hope I am explaining the technicalities clearly. Say on the types of information that we agree can be shared, and I think we can have a system under which it can be done automatically at each clinic. So if we spell out specifically what sort of information are needed or should be put in the database, then we need to be careful that about the difficulties or the hurdles in making changes, deleting some or adding more in the future. Okay, Chairman, there's the talk of safe deposit box. Of course, the patient may have some information that doesn't want to be known. But if a patient decides to withdraw some information, that could defeat the purpose. That a patient must have a reason for withholding some information. But other doctors or hospitals might have a reason for wanting to know that kind of withheld information. So is it a practice overseas that patients are allowed to withdraw or withhold some sort of information? Is that a practice overseas? And that's exactly what we were discussing. And the issue we faced during consultation. Many people had the same view as you, Ms. Lau. Say, if you want the data sharing system to be effective, then the patient should be willing to provide all sorts of information and not withhold any, because that would not be beneficial to the treatment of his disease, and neither would it be fair to the medical practitioners treating his body. Therefore, there were oppositions to letting patients withhold some data. But during the consultation, and some members also said that, well, this is an important issue. We should give patients the right to choose what information can be shared or not. I was asking about the international practice. Dr. Wong, you want to supplement? Thank you, Chairman. Hospitals do want to give patients the right to choose, but in terms of operation, it's quite difficult. In many places around the world, they did actually look into the same issue as well. Hong Kong is way ahead of other countries in terms of the design of healthcare system and penetration rate. I think Hong Kong can come up with its own practice. In countries where a similar system has been in place, none has been successful in carrying out a safety box. Even in Australia, it tries to adopt, in Australia, where it tries to provide a function of safe, some sort of safe deposit box, letting the patients control what sort of information they want to be shared. But they also found that there are technical difficulties because patients do not have a good grasp of what sort of information need to be shared by who. And also medical professionals also find difficulties in accessing all sorts of information. So there are technical difficulties. So looking at Hong Kong, we hope to serve elderly people mainly for each hour, mainly to serve elderly people or low-income families or people with chronic diseases or children. And we need to see whether it's easy in a society to implement a complicated system and yet they can fully allow patients to have the absolute right over what sort of data to be shared, and whether it's most beneficial to give patients the absolute right. Therefore, we want to implement the system first. We hope that the law can help us protect patients' privacy, security of the data, and respect patients' choice of right. I think members asked last time. The issues, concerns raised by members actually cannot be easily solved in this first stage. But I do hope that the public and members understand the whole purpose of the scheme. I know there could be other legal concerns as well. Who should be held responsible if mistakes occur. Well, we are now at the clause-by-clause scrutiny stage. We're looking at the section of interpretation, but then we've now jumped to later pages. Since we haven't got a member who's raised their hand, let me see if members have any questions on interpretation. Otherwise, we'll go back to clause 5. Interpretation. Members, any other questions? Lee Kwok Lun? Yeah, I hope that in the session of interpretation, you should spell out clearly to avoid unnecessary disputes. Over the past 4 years, it should know very clearly what it's trying to do. If we have a record that is shared, if under what circumstances some information is withheld, and if the treatment doesn't work, then who should be held responsible in the end? And also now, patients and healthcare providers' relationship is based on trust. So I wouldn't assume that, the patient, it wouldn't be assumed that patient or another party is withholding information. So in interpretation, if you don't spell out clearly the issue of ownership, then people would still be worried. If people are not clear about how the system works, then a lot of disputes about rights could occur. To me, this bill is nothing to do about rights. This bill is about, enhancing the effectiveness of treatment. So we need to make this very clear.
All right, I think we can continue. I think we can move on to the next part, please. Thank you. Part 2, the establishment of the system. Healthcare providers and healthcare recipients can apply to join the system. And first of all, the parties need to give a sharing consent. Now, say, for example, a patient has joined the system and 20 medical organizations in the market have joined the system. It doesn't mean that all the 20 organizations can have access to the patient's data. The patient or the healthcare recipient needs to specify which medical organizations can have access to the records. What I mean is not that we should start part 2, but rather we should continue with clause 2. Clause 2, bracket 2, identifiable data, non-identifiable data. Yes, Chairman. Just now, a member asked about the definition of parent. Should we start from there? Perhaps we can start from substitute decision maker. You mean back to the definition of substitute decision maker, Chairman? Yes. And I would like to refer members to Section 3. And Section 3 states who can become substitute decision makers. Yes, perhaps we can look at 3.2. If the person concerned is a minor, then there are these eligible persons who can be substitute decision makers. Parent, guardian, under the relevant ordinance, and then a person appointed by the court, and then in the absence of these persons, an immediate family member, and then E, in the absence of the persons mentioned in the preceding paragraphs, the prescribed healthcare provider, in other words, that clinic, that hospital, or that home for the elderly, can become the substitute decision maker. So these arrangements apply to minors, those under 16. And then subsection 3. A person who is mentally incapacitated as defined under the Mental Health Ordinance, or he is incapable of managing his or her own affairs. Then we have under subsection 4 that there are these persons who can be the substitute decision makers, namely a person appointed under the Mental Health Ordinance to be the guardian of the healthcare recipient. B, if the healthcare recipient is placed under the guardianship of the Director of Social Welfare, then the Director of Social Welfare. And then if the E, if the court has appointed a person to manage the affairs of the healthcare recipient. And then finally, in the absence of all these persons, an immediate family member of the healthcare recipient. And then G, in the absence of all such persons, and in fact I think this is a rare case, then the prescribed healthcare provider can make the decision. So that's all, Chairman. Dr. Joseph Lee. Now I think the definition of substitute decision maker is very clear. So I must praise the administration for that. But then concerning these minors, mentally incapacitated persons, what sort of records can the healthcare providers have access to? Now, say for example, I may want to let the healthcare providers have access to my records, but not the records on my mental problems. And this is back to the, my first point. I think this is the fundamental point. Now, I want to say that the definitions are very good. They are very clear. I mean, for substitute decision makers. So, who can be substitute decision makers? It's clear. This part of the bill is good, but we have to go back to the fundamental point. We don't want to give rise to unnecessary controversies. All right, is it that you have to go back and think about it? Yes, Chairman. Miss Elizabeth Quat, Chairman on substitute decision makers. Now they can help the patients make a decision. But what if some of these healthcare recipients recover or their conditions have improved, and as a result they can exercise or they can make their own decisions. And what if they are of the view that the decisions made by the substitute decision makers have produced adverse impact on their health or recovery? Now for the substitute decision maker, it's important that when he makes a decision, he really has that right to do so under the law. In other words, say if he makes a decision, the person is a minor, and so he is not exercising that right unlawfully. And then when the minor reaches the age of 20 and he doesn't want to be in the system anymore, then of course he can withdraw from the system anytime. Yes, I understand that the patients can withdraw from the scheme anytime. Now, say for example, he's under 16, and then a substitute decision maker makes the decision for him. And then when he reaches the age of 18, or at what age can he make his own decision? 16 or 17? So what if when he comes of age, he is of the view that the decision made by the substitute decision maker on his behalf when he was still a minor has adversely affected his health? And also it is said that in an emergency situation, the healthcare personnel can make a decision on his behalf. And what if he reaches the age of 17 and he doesn't like the decision made by him on the substitute decision maker? So is there any retrospective effect? All right. So we are here talking about minors as well as people who are mentally incapacitated. Now, say if that person can't really, or if the patient can't really make a decision because he's a minor, because he's mentally incapacitated, then the substitute decision maker is lawfully making the decision. Then when this minor reaches the age of 16, or when a mentally incapacitated person has recovered, then you're asking whether he can, say, sue the substitute decision maker for having made a wrong decision in this view. I think I'll have to defer to my colleague to answer the question. Dr. Wong. Chairman, concerning a mentally incapacitated person or a minor, when he is no longer incapable, then can he sue the substitute decision maker? Yes, in theory, the answer is yes, but then it says very clearly that the substitute decision maker has to be an appropriate person, and there are certain riders or conditions. The patient is incapacitated, or he is under the age of 16, or he is over 16, but he doesn't have the capability to make the decision. And only under such circumstances can a substitute decision maker come in, and the substitute decision maker has to satisfy the prerequisites in the bill. And also the substitute decision maker has to make decisions in the best interest of the patient. And so if I think it really depends on whether the substitute decision maker at the time of making the decision was really eligible, and whether he made the decision in the best interest of the patient. So in other words, the patient can take civil action against the substitute decision maker. but of course depends on whether the judge accepts the case. But I think strictly speaking, the action will not be taken under this bill unless we're talking about subsidiary decision makers who in fact made the decision on behalf of the patients unlawfully. Dr. Leung. I want to say concerning the IT aspects, are they governed by this bill? Now, in fact, we are in the course of clause-by-clause scrutiny, but it doesn't matter as no other member has a question. So, this is only the second meeting, and you've already started clause-by-clause scrutiny because many questions were raised last time. I'm talking about technical changes to the system. Say for example, alterations to the doctors' computer systems and so on and so forth. Yes, Chairman. Will not specify the models, the specifications concerning the computer systems, because as we all know, technology advances on a daily basis. So maybe the technology that is very advanced today may have become outdated next year, and so the office will need to, from time to time, issue circulars on new technical requirements. Say, for example, if a new virus is detected and that virus targets e-health record systems, then we'll have to issue circulars to medical organizations. But someone will have to be responsible for the technical aspects of the system. For example, some applications. All right, it seems that you have very stringent security requirements. For example, you have to specify the computers concerned. But then, you know, there was something about a decade ago called PC Anywhere, and even if I'm in a remote place, I can have command over my computer in the clinic. All right, so if such changes are required, then will these be taken care of in this bill, or will those be administrative decisions?
As I said, we don't stay in the bill technical specifications. The bill actually in clause 18 bracket 2 is intended to address what you just raised, that the commissioner has the power in relation to systems for data sharing, lay down certain specifications. So as for specifications for the system, the power to make changes lies with the future office of the e-record office. So there should be a mechanism that says that when the commission exercises the power, there should be some guidelines to follow and consultations, right? Because we are the users, right? If you keep changing or making changes to a system, and if I do have high expectations, then is there a chance for us to make suggestions? Yes, we do have internal working groups that will communicate with future users. If there are to be new requirements for the system, as I said, if there are changes in some medical terms or replacements for some medical terms, then we do have a doctors panel which we will consult. Yes, we've been using the HA system. As far as I know, your proposed system to a large extent is modeled on the HA system. But I know HA system has all sorts of problems. It's just that when you use, for HA, there are no competitors. So within HA, nobody has to be accountable. IT staff will, in the authority, continue to keep the system running. And users think that, well, they want to see improvements made. And yet the IT people are not under much pressure to make changes. Of course, I'm sure users and explorers sometimes have differences of opinions. Maybe I ask Dr. Zheng to explain to you. If a user finds problems with the HA system, who should the person complain to? Yeah, CMS, someone responsible for CMS, what actions can be taken? So HA is just for reference, the HK case, right? Yes. So you're saying that in the future you adopt a similar system? Yes, Dr. Zheng is also a designer of the new system.
Be more precise. So I'd like to answer the question actually is, in the future, this system, since it's being developed for the private sector, how would we make sure that the system meets the needs of the private sector? So in that sense, we actually have, as mentioned before, we have various working groups and committees which actually involve members of the private sector sitting together, both private hospitals and clinic level providers, and they sit together with us to work out what are the features that are needed and moving forward. So if someone raises, this is the sort of thing that I would like, we discuss it in the group and everybody agrees this is what we want, and then we prioritize the list of things to be done, and then we do that. And while doing it, of course, we maintain communications with them to make sure this is what they want. So that's what the intention well, it's already started, of course, with the development of the system so far in the EHR space. In the HA, there's a similar setup. Of course, the HA is complicated because we have so many users. So at the moment, we actually have a series of committees and so forth where these issues are discussed and percolated upwards. The difficulty there is that, again, we have, tens of thousands of users. So what we've actually done most recently is actually made it much more easy for individuals to directly communicate with the IT team, and we've done that through electronic means. So we have, for instance, set up a place where individual doctors and nurses can, simply write in on a website their comments and their suggestions, and then we, as much as possible, try to feedback them directly. And it's one of those, it's like a discussion forum type of setup, so that we try and answer the questions as quickly as possible. And again, any significant issues that are raised, we then put it back into the mechanism to prioritize and develop new features.
Well, I think we are going to be overrun. So, well, we've got two members who've asked to speak. Maybe, you can ask your question later. But this is just for reference anyway. Now we've got two members who've queued up. We have to draw a line. We need to finish this meeting at 10:30. Emily Lau and Kwok Pui Fan. I think let's speed things up because we haven't got 10 minutes left. Ms. Lau? Chairman? I think Mr. Liang said it right. I wasn't here, I know, last time. But I didn't expect we didn't expect us to start a clause-by-clause scrutiny in the second meeting. But then we haven't really addressed basic questions. I think now, even if we're having the clause-by-clause scrutiny, we need to go back to some fundamental issues. But now I think we need to handle the basic questions first. One is, in the past, when we had meetings, at the subcommittee, we talked about private doctors. Many of them don't have even computers. So I was scratching my head back then, and I know doctors, these doctors' writings are intelligible. So basically, under the system, you expect the doctors to have computers and know how to use computers. Can you tell us how much do you know among private doctors? How many are willing to join the system? If many are still remaining in the Stone Age, it's pointless if doctors, the private doctors, don't have computers. Do you think that's an issue? I think you asked a similar question last time. Thank you. Yes, indeed, in the private sector, the use of computers does vary. Doctors who are trained in HA and who later set up the private clinics, they can be highly computerized. But there are doctors who still rely on paper and pen. If they rely on paper and pen to make records, then it's really difficult for these doctors to join our system, because we do have requirements for computer connecting or networking. We have to make sure that their computers are compatible with our system and can be connected to our system. So we're going to actually increase the publicity with the medical council, and we've also developed some easy-to-use computer softwares that can be connected to our future system. We will provide such softwares for free to these doctors running their own private clinics. Of course, this installation may not be done over time, that all private clinics will take part in the system. We understand that time is needed for the doctors to get used to using computer. I was asking you how many private doctors were not using computers. This is not something, to do with privacy, right? What's the percentage like? And in the future, if you're providing them with free softwares, with a benefit to them, indeed. But of course, not all will accept your software. So if they don't use the software, will it affect the implementation of the system? Yes. We carried a trial scheme before, letting the participants to read HA records unilaterally. Of the 3,000 participants, 2,000 of them were in private practice. They were involved in a trial scheme to access HA records. But I was asking you the percentage of all the private doctors. What's the percentage like? May I ask Ms. Lee, how many private doctors there are so far? There are about 1,300 registered doctors, but not all of them are in practice. My estimate is that 10% are not in practice, and of the remaining 11,000, about a half are in public hospitals. So we estimate that of the private doctors, excluding those who used to work in private hospitals, there are about 5,000, 6,000 in practice. Just as Mr. Chen said, those who PPR, EPR numbered 2,000 private doctors. So these are all private doctors. The trial scheme was intended to let these private doctors have unilateral access to public hospital records. We estimate that about 40% of these private doctors were participating in the scheme to access public records. Do you think this is ideal, this figure? I mean, to have 2,000 doctors participating in the trial figure, of course, is good. But compared to the total private doctors of 5,000, of course, we'd like to see more involved in the scheme. But often, private doctors have their own habits. So it takes time for people to change their habits. So those in private hospitals, those in hospitals or medical organizations, they should all be connected, computerized. Yes. As I said, we have developed softwares for private hospitals, and of the 11 private hospitals, 8 are using our softwares. The 3 others have expressed interest. Now I'd like to see if you want to extend our meeting for another 15 minutes, or do you want to wrap up? Chairman, I think that you shouldn't limit us to 5 minutes. Because some members, actually, if you give them 10 more minutes, they could have go deeper. They could have gone deeper into an issue. And we don't know when we have a chance to ask the questions next time, because there could be clash of meetings. So I think for scrutiny of a bill, we need to be given sufficient time. Even a member can be given 20 minutes to ask the questions he wants to ask. So what do you think? Do you want to extend the meeting? How many have queued up? Corporate fan, 1. Let her ask a question. Well, extend a meeting first, and then corporate fan, you have the chance to ask a question. Yes, Chairman, I think we jumped too fast. Last time I asked some questions, and yet I haven't got answers from the administration yet. Last time I asked about the commissioner and the structure and the financial estimates. The government promised that they would give us the details. Example, the operating body, the system, the commissioner, structure of the office, financial estimates. What are the arrangements for all these? I also asked about questions in relation to the second stage development of the scheme. So can we be given the details at our next meeting? I was expecting an organizational chart, so we could then look at each of the subhead or subdivision in the organization. But somehow we jumped to other issues today. Well, because we didn't really look or ask about the organization this morning. All along, we said that. Sorry, she's not speaking through the mic.
Well,
there are 2 papers. There were 2 papers actually provided to us by the administration. But she's not speaking through the mic.
仲有一份係 CB 21538。
CB21538. That's another paper with the administration's response. I think if the administration could, give us their response earlier, then, we received this paper on May 16, Friday, so maybe members didn't have time to read through this document. I have 2 papers, but paper 1538, I haven't got it. So, Chairman, firstly, I think the administration should have given us their responses earlier. I don't know how urgent it is for us to pass the bill, but lately we have so many meetings that clashed lately. We can only meet properly on Monday and Tuesday, and we have to go from one meeting to another, And so previously, if our basic questions asked were not addressed properly, then Chairman, please exercise your discretion. Even if we now enter the stage of close-by-close scrutiny, we should be allowed to go back to previous papers.
No problem. I think 2 members have put forward the same view, and so next time I will give members time to go back to the policy issues like the organizational structure of the commissioner's office, the powers of the commissioner, and so on and so forth. All right, so next time. But then, Ms. Ho, our next meeting will be held on the 26th, and that's going to be a public hearing. The public hearing will start at 4:30 p.m. I don't know how many deputations will be coming, and if there aren't too many, then we, after meeting the deputations, can continue with the discussion, and we can perhaps first of all deal with paper 1538, and then after we've cleared all the policy issues, we can go back to clause-by-clause scrutiny. Right? Do members have any further questions? Then we can finish early. Not early. I mean, we do not need to go until 10:45. All right. So let's ask the administration further questions next time. I don't know why I can't find the paper. Maybe the paper came rather late. I really can't find the soft copy, but I understand that the hard copy has been tabled. No, I really don't have the soft copy. I'll check whether I've really been given that soft copy, because that was why I missed this paper. I believe the paper was issued only on Friday, rather late. I hope that the administration can bear in mind that papers should be issued to us 2 working days in advance. If we can't receive the papers 2 days in advance, then we can cancel the meeting. I can remember our fixing the rules when we dealt with Article 23 legislation and the school management incorporated, right? So the administration should address next time issues like the safe deposit box system and also the ownership of the e-health records. So please give us more background information. I understand that you've given us a reply today, but please give us the background information, overseas practices, and so on and so forth, so that members can read the papers, because different members may come in at different time during the meeting. All right, I think we can now adjourn the meeting. Thank you very much.